Thank you very much indeed. And thank you, Tom, and to the Society for inviting me to talk on this topic. Of course, I made the mistake, as one always does, when it's many months ahead of the event, you don't look at the title and you say yes. And when I came down to actually studying the title in more detail, I realized that I needed to be clairvoyant, which I am not, but I'm going to have to try and be that. So let us move on then to the talk. Firstly, I want to say how very pleased and indeed how honoured we in Ireland are that the British Hypertension Society is coming to Dún Laoghaire in 2016. We're honoured and we feel privileged that you're coming, and I can assure you of a very great welcome and Irish hospitality at its best when you do come to us. It's an important year for us, 2016. It's the centenary of our independence, as it were. And I think in the 100 years that have passed since that date, I think we have matured as a nation, and I think we in Ireland and you in the United Kingdom have come to recognize that we each need each other very much, that we each give to each other a lot, and that we have supported each other in many ways in the past. I think one way in which we have supported you very strongly is in trying to preserve your beautiful language in conversation, literature, and music. But when you come to Dún Laoghaire next year, I hope that you will come as the BIHS, that is the British and Irish Hypertension Society. And after dinner last night, Mr. Chairman, I did a little bit of rebranding, and I also checked on the internet to see if by any chance the BIHS was an escort agency or a bordello, and I've discovered that it's none of these. In fact, it removes the onus that you have of being confused with British home stores, and is in fact a very other good reason why you might change your name and join us in Ireland. All right. Well, certainly from our point of view, we would welcome this very much. And not only because it would, I think, serve the society well in that we would bring a number of members who otherwise do not attend this society, but I think it would enhance greatly the interchange between us. It would facilitate clinical trials. And indeed, as Annette Neary, who proposed this, pointed out yesterday at the meeting, it would allow us to bring a certain amount of largesse, and I won't emphasize that too much, to the society. But talking to Mark Caulfield last night at dinner, it occurred to me that perhaps we should leave the politics to one side and consider the benefit that might follow from such an association, namely to the people who have hypertension. And in this talk that I'm about to give, I am going to concentrate on the UK figures and the UK status of hypertension, because that is the data that is the best data I can find. And unfortunately, the Irish data is very poor. So we have a population of nearly 5 million, 1 million of whom have hypertension, and 700,000 we estimate are uncontrolled. And this is a very poor situation. We have 10,000 strokes a year, which are largely preventable. And so we have this very badly managed risk, and we need your assistance. And so looking at it purely from the perspective of nearly 5 million people who have hypertension and need help, I think there is a very good reason for this change in name and status. So having said that, I'll move on to my topic, and I'm going to discuss it under 4 headings. First of all, I'm going to look at some of the facts as they exist, and again, my facts are taken from what's happening here in the United Kingdom. I have used a number of publications. I'm just going to show some of them. Neil Poulter features in a number of these, and we know from his masterful lecture yesterday how much he has contributed. Public Health in England is an interesting initiative. We have to look at some of the World Health Organization strictures on hypertension, the Atlas of Risk. And if we look just in broad terms, the leading causes of death in perspective, of course, heart and circulatory disorders are very much to the fore. We all know that. And if we drill into that a little bit more, we find that high blood pressure outweighs all other risks. So let's not be embarrassed about the fact, I shouldn't say embarrassed, but let's not belittle the fact that we are a hypertension society, because we've every good reason to be. If we were to deal with nothing else other than blood pressure, we would improve the health of the world enormously. That's not to say that we ignore the other risks, but that we realize what we are. I could put up any number of statistics. Hypertension is now dubbed as the largest epidemic ever known to mankind. And that's interesting on a global scale. It's the biggest risk factor, of course. 1 in 4 adults have it. That's about 12.9 million in the UK. 5 million people are unaware that they have hypertension. Diseases caused by high blood pressure cost over 2 billion per annum to the NHS, and 12% of all visits are to GPs because of hypertension. So we have a very big problem here in the UK, and we've to add to this bill that's up here cognitive impairment, dementia, and other cardiovascular diseases that are a consequence of hypertension. So let's be in no doubt about the fact that we have a very big problem and we have a lot of work to do. There's been positive change in the last decade. Moderate drop in the average blood pressure. In the UK, 2 million people newly diagnosed, a 10% increase in blood pressure control. This is all very encouraging. If this improvement continued until 2022, 80% of treated patients would have blood pressure control, and the potential annual savings would be 50,000 major cardiovascular events. The financial estimates are there as well. A saving of 120 million if we got a 15% increase in diagnosis and treatment, and another 120 million if we increased blood pressure control further with a substantial saving. And if we look at other ways of estimating this, we can see that things are improving. The only thing that's deteriorated there is body mass index. It all looks good, but there's one major caveat, and that is obesity and the metabolic syndrome. And we've also got to compare ourselves to other places. We've improved in England, but Canada's doing so much better. Now, why is this? And it might be a useful exercise for us to compare what's happening in Canada as to what we're doing here. Our performance to date, again, can be measured in different ways. The percentage with blood pressure diagnosed or undiagnosed, the percentage with high blood pressure achieving control. And again, if we look at Canada, it's remarkable what they're doing there. So I think we could use the comparisons to gain some insight as to how we might improve things more in the next 50 years. Looking at lifestyle, well, again, I'm indebted to papers such as ones from Graham, and we've also got to take into account other investigators such as those in the PURE study. I know it doesn't perhaps achieve, how shall I put it, the recognition that I feel it should achieve. It is science, and we've got to be able to balance other viewpoints. The guidelines, of course, of the BHS have been invaluable. And then if we look at the risk factors for developing hypertension, we have the unmodifiable versus the modifiable. And we know that lifestyle factors, if effective, do result in a fall in blood pressure at all interventions in relation to lifestyle. And there are many recommendations that are there. I suppose the most disappointing thing about lifestyle recommendations is how ineffectual they seem to be. And this is something that we've got to ask ourselves why it is that in spite of all we're doing, the overweight and obesity is increasing and is a very, very substantial problem for us in the future. The recent trends again show us that everything is getting better except for these two, the two sort of elephants in the room, as it were, that we seem to be failing very badly with. Now let's move on a little bit to the future needs in relation to hypertension. And I've sort of divided these into headings again. I'll say a few words about treatment, although after this morning I don't know that I can say anything about treatment. I want to say something about single pill combinations. I want to mention registries of hypertension and education of the public, which is a strangely neglected area that I want to turn to. And I'm not going to say very much about future research other than to acknowledge that it's been well covered by others. And again, in my search of the literature here, I'm obviously very dependent on the NICE guidelines, obviously the pathways. So much more was said about this morning, indebted to Brian and Morris and their team for the work they've done on this. Again, Neil and Mark Oldfield's seminar on hypertension, I think, has been an invaluable contribution to the literature. It summarizes in a very succinct way a very complex subject, and I think has to be compulsory reading for anybody who's interested in hypertension. And then we have the Spanish registry study, which is really quite remarkable because it shows us that the way we've been measuring blood pressure has given us a very warped view of what's actually happening in the world of hypertension. And then we come back to the recommendation. This is from NICE, but it's based on Morris's work on the format for treatment, which I think holds very well. So let's just think about treatment a little bit. New drugs. Do we need new drugs? I don't think we do. They're very welcome if they come, but I think we've got to learn how to use the old ones, and we're doing that slowly and very gratifying again with the pathway study to see us at least looking at that. But we've a lot to learn about the old drugs. We've got some damn fine drugs there, and I think we've just got to use them in a better fashion. I'll return to that in a moment. We've got to answer this question of whether it's ACE inhibitors or ARBs that are better. I'm afraid I'm not convinced. I know many would argue with me, but I think we need to definitively answer this question. And I made this slide a day or so ago, and I couldn't anticipate what was going to happen this morning. It's nice to see that thoughts of 24 hours ago are now sort of defunct, as it were. And to answer the issue of thiazide versus thiazide-like versus chlorthalidone, well, now we've extended the diuretic story, and this is good, and we must continue to do that. Resistant hypertension, when I made this slide 48 hours before the pathway studies this morning, I said if you give spironolactone to patients with resistant hypertension, it disappears. It's very interesting that I was asked by a private hospital in Dublin, would I set up a hypertension clinic? I was asked by cardiologists in the private hospital, the management. And this, of course, was an interesting point because cardiologists generally have shown no interest whatever in hypertension, and yet suddenly here they are interested in hypertension. And that was for no other reason but that renal denervation was a way of augmenting a falling income. But we'll leave that aside for the moment. The SPRINT study is going to entertain us for some time. How low should blood pressure go? And I think on this aspect we need to see the data and study it carefully. And then when we come to interventional techniques, we have a number of them. We've renal denervation, baroreceptor stimulation, we've the AV fistula technique, which Mel Lobo and Alice Stanton have published on recently, and we've other techniques there. And I think what we've got to do with all interventional techniques is rigidly apply the same principles as we do for pharmacological interventions. And I think the simplicity debacle, if I can call it that, is going to become a cause célèbre in the future. And a forensic journalist with medical knowledge will look at this, and it really will be seen as something of a disgrace for science that renal denervation ever was allowed to proceed the way that it did proceed. And if we had applied the same principles as we do for pharmacological studies, this would not have happened. And I think we've got to ensure that it doesn't happen again, and that before an intervention is put forward, it must have passed good scientific principles, good scientific studies. Now, it would be good if we had an interventional technique, and there is something in renal denervation. I'm not debunking it completely. It does, if you interfere with the sympathetic system, you bring down blood pressure. We've known that for 50 years, since sympathectomy was first introduced. I think what would be good about renal denervation or other techniques would be that it would offer hope for people who are intolerant to drugs or people who simply will not comply with treatment. But that's all for the future, and it's good to see that there are proper studies. I want to talk about single pill combinations. I once listed them as flexi pills. I prefer the term flexi pill, but single pill combination has caught on, and let's keep with that. On the Irish market, and this slide was made a little while ago, we have a large number of SPCs available. The triple single pill combination, just to give you an example, has olmesartan and amlodipine and hydrochlorothiazide in low doses. And then you can step up a little bit to medium doses of one and low doses of the other, and finally up to higher doses of all three. Now, I think this is actually a remarkable approach, and I find in practice that having the use of, not necessarily this one, I'm just giving this as an example, having the use of single pill combinations allows one to approach your patients in a much more different way than you would if you just had monotherapy. You can give 2 or 3 drugs in one tablet, but you can give flexible doses of 2 or 3 drugs in one tablet. The lower doses, of course, fewer side effects, and I think you definitely do get improved compliance, and you can reduce not only the mean blood pressure, but you can use, for example, amlodipine, which does seem to affect variability. You can use that to also hit variability. And I think this is broken down, but I think they've given me a spare one, yes. And we can reduce therapeutic inertia. Let me say a word about therapeutic inertia because it occupies our minds quite a bit. And I think it's wrong to blame doctors solely for therapeutic inertia. And there's a tendency to blame GPs more than ourselves, as it were, in a general sense. And this, I think, is wrong. Because if we think about therapeutic inertia, it's really it's a fault of a relationship, the relationship between the patient and the doctor. Because you're faced with a patient who you've prescribed a drug for, and the patient comes back a month or whatever it is later, and you say, sorry, your blood pressure is not well controlled. I'm going to have to give you another tablet. And you have to do that then a month later. The patient is resistant to taking more medication, understandably, and you as a doctor are resistant to give more medication. In a sense, it's a failure on your part not to have given it. So we're faced with the problem of a joint aspect or joint approach to it, whereby neither the doctor nor the patient wants to take more therapy. With the single pill combination, one can say to the patient, well, look at the tablet I gave you the last time. I'm just going to alter the cocktail a little bit, but you'll still be only taking 1 tablet a day. And then you have the option to do that another time as you increase the mixture even more. So I think we really do need to look at SPCs in a more positive way. There is remarkably little in the literature on it when you go to examine it. Moving on to registries. I've been very keen on registries for a long time, and I'm involved in trying to establish registries in Ireland for a whole thing of skin disease, but I won't go into that with you now. Why I'm involved with dermatologists is a rather oblique aspect of my endeavor. But registries have become a discipline. They've become an industry to some extent, and there are, as you see here, books written on it. And the US Hypertension Registry has been shown to be very effective if we just look at control, increasing control from 44 to 80% over a period of years. And there has been a good literature here showing that registries benefit everybody. And we have been slow here to actually establish a registry, a hypertension registry. And the beneficiaries are practicing doctors, because we can have improved organization and management, and we can implement guidelines through registries. Healthcare providers are helped because the procedures, the effectiveness is shown in practice. Drug and device manufacturers, of course, benefit and give some guidance for future development. Scientific researchers can acquire generic consent through registries. And patients, the people who we are there to serve, are best managed by evidence-based guidelines. And of course, patients, if involved in trials, do much better. This is a well-established fact. I almost feel that patients, regardless of what their disease is, they should all be in a clinical trial of some sort. All right, on to the issue of education of the public, which I want to touch on. And if we look at various quotes from various places. It's shown that, yes, patients do not retain information. And if we look at recommendations, we find environment, empowerment, encouragement. Where's education? The 4 E's that should be in there. We find various recommendations for the management of hypertension using various approaches, such as group therapy, whatever it might be. But I have to ask myself, has nobody ever heard of the app? It seems as though they haven't. There are 500 million smartphones in the world. It is the most extraordinary form of connection with the public. And I think we've been very, very slow to use it. There are 1.6 million apps available. 100,000 of these are health-related apps, but only 103 are FDA approved. So there's a big problem there. But the mechanism is there. I wrote a book back in the late 70s with Kevin O'Malley called High Blood Pressure, What It Means for You and How to Control It. And the book was fairly popular. We sort of went around the place talking on radio about it and various things. But, you know, I think only 1,000 issues were printed or whatever. And I was persuaded to revise it, and I said to my son, I'm going to revise it, I'm going to make an e-book out of it. And he said, no, why don't you make an app? This was about 5 years ago. I didn't know what an app was at that time. And I found out fairly quickly as I embarked on the course of making an app. And I did make an app called BP Expert, a pilot app, and we put it out there, and it was interesting in the sense that it got some good reviews. I was very flattered by the one from the Lancet, which said, easy to use, comprehensive, and with video presentations by a man I wish was my doctor. I was quite chuffed by that. But anyway, the app went out there, the pilot app, and there were lessons to be learned from this, and I want to sort of share them with you. We reached over 10,000 people without any promotion of any sort. It just went out there, and 10,000 people, I like to think, were better off or better acquainted with the problems of hypertension than beforehand. We reached all around the world, a thing you couldn't do with a book under any circumstances. And there were requests back for interaction with the app. And I realized then that I couldn't really interact because I was doing this bit of a one-man show, and I needed somebody who knew the global aspects of hypertension. And I asked Neil if he would join with me in revising the BP Expert app. And I'm very happy to say that he did that. And we now have the app ready, and it's going to be free to everybody. It's not going to be a charge. And that's an important point, because now we can really promote it in a way that wasn't possible with the pilot app. And we have a question and answer function built into it for an interactive aspect, and this will be launched in October. Coming now to research recommendations, these have all been well made by NICE, and I'm not going to repeat them. They are there. I agree with them all. And then they were made again by Neil and Mark in their seminar. So there are plenty of issues there for future research, many of which were answered. I think one point I would pick up is that we should look at the heterogeneity of hypertension in relation to specific levels, be it systolic or diastolic pressure. We also need to think about the comorbidities with high blood pressure. I'll close now by just touching on, and you know I couldn't leave without touching on measurement. I think some of you would have been relieved if I had, and others might have been disappointed. But anyway, here we go. Measurement has fascinated man since the beginning of time. It's just part of our makeup. We like to measure things. And I've depended on a number of publications. Some of them I'm involved with in relation to things. And of course, we've had the Richard McManus, who's the chairman of the Measurement Working Party, and has done a lot of good work in this area with the European Society, and we have other papers such as that from Brian on central blood pressure. Dr. Fraught in 1918 said there are so many instruments on the market, it is difficult to separate the good from the bad. Well, I think poor Dr. Fraught would be distraught if he was living in this age. We live in the age of measurement. Or perhaps I should rephrase that. We live in the age of inaccurate measurement. Most of the measurements that are being done are inaccurate, and it's very difficult to change this. I tried to do it with the Dabble Educational website, and I'm just going to briefly make the point here that I had to leave this website, and Neil Atkins left with me. We had founded it on scientific principles, And when fiscal avarice took over, we departed a year or so ago, and we set up a new website which is called Medaval. And this is a standard for medical device evaluation. And I think it's timely for us to do this because there are so many cardiovascular now, we're only interested in cardiovascular measuring devices on the market. We brought with us an advisory board, an international advisory board. Most of these were previously on the other website, and they've left and joined the Medaval website. And George Sturgeon is deputy chairman, and Neil Atkins is the device analytic person behind this. And this website has, for example, over 900 blood pressure measuring devices are up there, and they give details on the validation process that has been used for each website. I've just put up a sample here. I thought it appropriate to do it for one of the sponsors of the exhibitions here today. And it will also give you the publications relating to it. And we hope to look at other measuring techniques in the future to see if we can bring a system to bear that will ensure that devices are accurate. We've started to do it with blood glucose meters. There are over 400 blood glucose meters on the market, the majority of which have been untested. And we think hypertension is a difficult measurement, but blood glucose has much more implications in the acute sense than others. I think when we look at out-of-office blood pressure measurement, we've got to be a little bit iconoclastic in the way that we deal with things. I put up two quotes here, not to say that I told you so, but rather to say that it has been obvious to us for many years why ambulatory blood pressure measurement or home blood pressure measurement should be better than office blood pressure measurement. Any primary school student knows that if you have a variable and you measure it many times, you're likely to get closer to the mean. So I think we've got to be careful not to become obsessed with evidence-based medicine. When there is something that looks as though it is very rational and very reasonable, we don't dispense with getting the evidence, but we do implement it into practice whilst we accumulate the evidence, rather than banning it, as it were, from clinical practice whilst we wait the evidence, which may take 20 or 30 years. And these are just examples of the type of patterns that you get with different clinic blood pressure measurements, the number of patterns, or with a clinic blood pressure, the number of patterns that you can get with ABPM. And it took us until 2011 when NICE boldly made this statement. And this statement has been followed now in the US Preventative Service Task Force draft. Note, they are only draft recommendations, but I think they will become a fact. So the US has recognized what NICE has said, and we should be performing ambulatory blood pressure measurement. But let's not become obsessed as to whether it is ambulatory or home blood pressure measurement. Why can't we develop a device for all seasons? A device that will measure clinic blood pressure, that will measure home blood pressure, or that will measure 24-hour blood pressure or 48-hour blood pressure. The technology is there, and it can be done. And we've got to get inexpensive, accurate technology that will do this. And I've researched this very carefully. We can get these devices for under £200 per device. And yet we're being charged thousands of pounds for devices for ambulatory blood pressure measurement. This has got to stop, and we've got to stop it. It is up to us to do it. We've got to tie in innovative software, and that is available to us as well. We've got to have central hosting so that we can have data retrieval for registries. That is very important, and we can make sense from it. And we've got to make ABPM widely accessible. Pharmacies are a good example. It's available in pharmacies in Ireland. We've got to combine Holter monitoring with ABPM to embrace the epidemic of atrial fibrillation that is occurring in our hypertensive patients. So in conclusion, let me just say that if we can't measure it, we can't diagnose it. And if we can't diagnose it, we can't treat it. But yet that's exactly what we've been doing for the last 50 years. So I hope we'll improve it in the next 50 years. Thank you very much, Mr. Chairman.